Hello everyone, I'd like to welcome you to our annual SIBO Update Webinar. I'm Emily, the Operations Manager here at SIBO Test. Many of you, I'm sure, have spoken with me over the phone or via email. Our presenter tonight is Dr. Nirala Jacobi, a licensed naturopathic physician and medical director here at SIBO Test. Dr. Jacobi participated in the roundtable discussion at the first SIBO Symposium held in Portland in 2014 and has worked nationally and internationally on SIBO for the past 5 years. She's recognised as one of the leading experts in SIBO treatment in Australia. Over to you, Nirala.
Thanks, Emily, and welcome everyone to tonight's webinar. It will be a very jam-packed presentation with lots of new information that you can hopefully use in your clinic right away tomorrow morning. And if you get tired, don't worry, we'll send you the link to the recording so you can review that at your leisure. At SIBO Test, we don't have any financial ties with any other company, so any mention of products or other services is made independently through my clinical experience and research. Having said that, I just want to take a moment and thank Oborn and Biomedica for helping us spread the word about this webinar. So what are we talking about tonight? Figure out my little clickers here. So tonight we'll be looking at some of the news and review, what's happened in 2015, 2016 since I've last presented this annual update. Oops. And also I've just returned from the 2016 SIBO Symposium, where I'll just be presenting some highlights from that symposium here later on. And then we'll move into the update in SIBO treatments and the new Bifphasic diet that we've constructed over the last year. There's some changes in the diet handout and how we're presenting it and how to treat SIBO. And then we'll move into antimicrobials, the new herbal antimicrobials for SIBO and SIFO, small intestine fungal overgrowth. And we'll have a small rifaximin update and then mentioning some noteworthy research in 2016 and then moving into question and answer. So we really have a pretty full schedule on tonight. If we don't get through everything and you have questions, we can also take them at the end and we can send around an email with all of the answers from tonight's questions. Okay, so let's start with the news and review of 2015 and 2016. So we've really put a lot of effort into relaunching our website, because here what we're doing is we're not just a testing facility, but we're also really focused on providing excellent practitioner education. And so with that in mind, we set out to rebrand our website to have an entire new practitioner section that is gated, so people have to log in to access all the handouts and information and education. We have a new blog that you can access where you basically will be having several different categories that are really exciting, and particularly I'm really excited about the SIBO Doctor podcast, where I'll be conducting interviews with experts that are related to the field of SIBO, because we know that SIBO is a very multifactorial condition, meaning it has its little fingers in lots of different conditions, and so I'm just very interested in learning more about all these different, whether that's inflammatory pathways, methylation pathways, environmental medicine. There's just so many different aspects that relate to SIBO in some way. So I'm really looking forward. I've already got a lineup of experts to interview, so just keep your eyes peeled to that space. We will alert you of new podcasts when they're available, but basically we're launching in August, September of this year, and we have already, like I said, some very good interviews lined up. We also are launching a SIBO practitioner in the Spotlight video, where we're talking to very successful practitioners that can share with us what makes them so successful. So that's also something that's coming your way. And we have a SIBO diet and nutrition section where Rebecca Coombs, who wrote the SIBO cookbooks, will be contributing frequently to give you some ideas and your patients some ideas as well. And then also some SIBO research is a category in the SIBO news section. We also have SIBO masterclass. They've been very popular over the last year. We're getting a lot of requests for this. This is a more in-depth workshop, 3 sessions that are 2 hours each, where we're working through basic to advanced case management as well as special topics. And the next class starts in September. Just a word about the SIBO Summit. We're really excited. I've been working on this for quite some time now. I've been really wanting to get Dr. Seebecker over here, and I've been successful in securing her to come over in October, and Dr. Jason Horlak, who's truly an expert in probiotic and prebiotic supplementation, but also just his knowledge in that field is just phenomenal, and his take on SIBOs is a little different. And then I'm also announcing Alyssa Tate, who is a physiotherapist, clinical nutritionist, and naturopath up in Brisbane. And I've been working with her quite a bit because of this whole adhesion and stricture issue that we see in SIBO, and a little bit on that later on. But she has a fascinating presentation at the SIBO Summit called Untangling the Web, Visceral Mobilization in SIBO. So I'm really hoping you can join us for the SIBO Summit. It'll be a live summit in Melbourne and in Sydney, and the early bird is ending at the end of this month. So in case you get lost, we're really building on our SIBO knowledge. So we don't really want to repeat ourselves with these updates and really maximize our time here. So if you feel like you're sort of not understanding things, or you're new to the field of SIBO treatment, please review the Foundations of SIBO Assessment and Treatment video, which is free for you to view in the practitioner resource section on the website. All right, so this is just my review page, and I hope that's the only review for the evening. But basically, if we're looking at SIBO, you have a case coming in. I hope you can see my mouse on your screen. But basically, if you have a case that is a suspected SIBO case, you would first do a lactulose and or glucose breath test to understand gas levels of hydrogen and methane. Then if the patient tests positive, you can either put them on an elemental diet, which is a protein formula with fat and some glucose that they consume for about 2 weeks, and that is the equivalent to either herbal antimicrobials plus the biphasic diet, or antibiotics such as rifaximin and neomycin and the biphasic diet. And just a word here that we have a real range of practitioners joining us tonight, and we have GPs, we have naturopathic physicians from America, we have naturopaths in Australia, we have all sorts of practitioners. So I'll be talking about all the different treatments, not just herbal antimicrobials. I myself cannot prescribe rifaximin in this country, but I often talk to physicians and practitioners about the use of rifaximin. So just bear with me even if you cannot prescribe it. So you've done that, and after a certain amount of time, if it's antibiotics and the biphasic diet, over here you would probably, that's about a 2-week course. Herbal antimicrobials take a little longer, and the elemental diet is also 2 weeks. You would then reassess your patient after a lot of time. If you see a 90% improvement in that patient's symptoms, you can move to prokinetics and the biphasic diet and move into a more preventative phase of your treatment. If you have partial improvements, we recommend that you retest your patient to understand the reduction of gases. If they're still test positive, you would either, if it's a significant drop in a very high level of hydrogen or methane gas, you would continue on with your antimicrobials, or at that point you can change antimicrobials, repeat rifaximin, or consider the elemental diet. if this patient tests negative for SIBO, but all their symptoms are still ongoing, then obviously you would consider another diagnosis or some involvement in the large intestine in terms of dysbiosis. So consider SIBO in chronic illness. This is something that's I find so fascinating, that very often when I speak with chronically ill patients, they have this element of digestive symptoms, or as an sort of overriding driver of their condition. Now, I just attended the Bioceuticals Research Symposium earlier this year in April, and where they had many prominent speakers like Dr. Perlmutter, who's well known for his work in, he's a neurologist, and he wrote Brain and talked a lot about neurology and the digestive tract as well, or the gut-brain axis. And then also Dr. Fasano was there, Dr. Alessio Fasano, very, very famous for his work in zonulin, or researching zonulin, and been credited with discovering zonulin, which is the little glue that holds our enterocytes together and is very much to blame when we see leaky gut, where we see high blood levels of zonulin. And so virtually every speaker at that symposium mentioned SIBO, which I found really fascinating. It's getting a lot of attention, and it's been sort of thrust into the limelight. Now, I had a little conversation with Dr. Fasano after his lecture and talked to him about SIBO, and he said really that the three cases or the three conditions where we can expect a rise of zonulin, and therefore an indication that leaky gut is occurring, is an acute case of gastroenteritis or food poisoning, or enteritis, or gluten sensitivity, or SIBO. Those are really the three where we see this occurring. Now, last year I mentioned that SIBO is well known to cause leaky gut, but typically after treatment we do see this resolve if SIBO has been successfully eradicated. But perhaps because I see so many advanced cases of SIBO, I do see this issue lingering quite a bit longer, even when SIBO has been eradicated. So I think it does as well to kind of understand this condition a little bit more, and to also consider SIBO in many of our chronic cases where we really think that leaky gut is part of the problem here. LPS and other bacterial endotoxins are the most potent trigger of inflammation, and LPS of course stands for lipopolysaccharide, which is an element and a substance that's being released by gram-negative bacterial cell walls when they're dying, and it's very, very much implicated in inducing the inflammatory cascade. So when you have leaky gut, LPS is just something that gets absorbed very easily. So just to have that as a plug, that even if you don't have somebody coming into your office that is presenting with the classic SIBO symptoms of bloating and really heavily, primarily having digestive symptoms, really still consider that as far as your chronic inflammatory conditions as a quick rule out, to see if they have at least some element of SIBO in this case. SIBO, again, is also associated with other cytokines besides LPS-inducing cytokines. It's independently associated with an increase in IL-6, which can cause a lot of problems in people. Just a quick update on the lactulose breath test. So what we talked about last year, which was really based on Dr. Pimentel's work at Cedars-Sinai. Dr. Pimentel is a gastroenterologist who leads the motility center at Cedars-Sinai Hospital, has done a lot of research into SIBO and breath testing. He's done over 20,000 breath tests at this point, and he talked at the SIBO Symposium of how he doesn't really use glucose anymore. But being a clinician, I can tell you that I still use glucose, and particularly if I have very chronic cases. And why? Because we cast a wider net if we use glucose as well as lactulose. So we would use lactulose initially and then use glucose as a follow-up. If I do just lactulose and I'm still thinking that it's negative and I still think SIBO is an issue, I will follow this up with a glucose breath test. Each substrate is fermented by different groups of bacteria. Sometimes you're lucky that you get them all on a lactulose, but that's not always the case. So I just want to encourage people to not move on from your possible diagnosis of SIBO if your lactulose breath test is negative. A little update on methane gas. The Methanobrevibacter smithii, which is the primary methanogen that's highly associated with SIBO C, which is SIBO constipation. We talked about how your patient feels best when, or Dr. Pimentel talked about how your patient feels best when methane is less than 3 parts per million. The breath tracker, which is what SIBO tests use and all breath labs usually use, is accurate to plus or minus 3 parts per million. So you can have a test result come back to you and it says 6 parts per million. I would consider that potentially negative based on the limitations of the machine. And this is just a little heads up on that. Methane is not produced, or basically methane is not produced by just the substrate lactulose, just as a reminder that it is produced from hydrogen. So methanogens are using the hydrogen secreted by hydrogen-producing bacteria to produce methane. So sometimes when you retest, you can see an elevation of hydrogen when the methanogens are being killed or when they're reducing in number, and that's pretty understandable. The new spot methane test is really helpful if your patient got high baseline, which stayed high during initial breath testing, meaning that you've got your patient's test results back and they basically are very high methane all the way throughout with not much fluctuation. This is a good candidate for having a quick spot methane test about a month into your treatment to make sure that methane is reducing. Spot methane testing is not very good for those who have fluctuating methane levels throughout their initial breath testing. It's very convenient, it's just a single vial, and it's very helpful to understand if your treatment is actually working. So this is an example of a methane that was high at baseline, but you can clearly see here, I'm just going to move my mouse very carefully, you can see here this is your control sample of here are parts per million of hydrogen, here are parts per million of methane, and this patient is negative, oops, it's a very sensitive mouse, pardon my scrolling here. So what we have here is a patient who's negative on hydrogen, but when we move over to the methane category, they're already positive at baseline, and then after 20 minutes after consuming the lactulose, they jumped up by 22 points. So this is somebody who's quite responsive to the lactulose. Now, as I've mentioned before, lactulose does not directly feed the methanogen, it feeds hydrogen-producing bacteria, which then in turn feed your methanogens. And so you will have an element of hydrogen in there, it's just not visible from this particular test result. And that's pretty common, so just have an eye out for that, or keep an eye out for that. All right, so moving into the SIBO Symposium highlights. Now, the SIBO Symposium is held in Portland, Oregon every year, and it attracts physicians and gastroenterologists as well as researchers who present their findings in their respective fields and as it relates to SIBO. So it's a real collaborative effort, and this year's symposium was really no exception. It was very, very interesting presentations on a wide range of topics, as you can see. I also presented there on the biphasic diet as well as the novel herbal treatments I'll be talking about a little bit later on in this section, or in the little later section. Now, the sections that I mentioned here, the underlying causes of SIBO, SIBO treatments in pregnancy and lactations, biofilms, Lyme disease, as well as IBD and SIBO, were all, I've summarized them as best I could so that you really get the salient points from these excellent physicians as we move through this. Okay, so starting out with the underlying causes of SIBO. Now, we've mentioned this in previous updates, but I think Dr. Seebecker really, and actually Dr. Lisa Shaver, did an excellent job with really making this as understandable as possible, because as you know, the underlying causes of SIBO are many. So we've sort of kept it into or categorized them into these three categories. One is damage to the migrating motor complex, where bacteria are not swept out of the small intestine. We've also looked at this altered anatomy and structure of the intestinal tract, where bacteria clearance from the small intestine is blocked. And then lastly, looking at altered physiology and function, where bacteria are not killed in the stomach or the small intestine. And just a quick review that the normal protection against SIBO in the small intestine is the migrating motor complex, which is the cleansing wave that occurs every 90 minutes on an empty stomach that ensures that everything is swept out of the entirety of the small intestine. Also hydrochloric acid, bile, enzymes, and the general immune system in the small intestine serve a function, as well as the closure of the ileocecal valve that prevents the backflow of the fecal content into the small intestine. So looking at these in detail, so damage to the migrating motor complex, again, bacteria are not cleared or swept out of the small intestine. This is really classic for post-infectious SIBO that we've mentioned last year and went into detail. Also, that update is also available at SIBOtest.com if you're still unsure as to what this means. So post-infectious SIBO is usually caused by 4 strains of gram-negative bacteria, and that's the Clostridium jejuni, Campylobacter jejuni, Salmonella, E. coli, and Shigella. And these release cytolethal distending toxin, which damages the interstitial cells of Cajal in the migrating motor complex, and in turn antibodies are formed from the body to this cytolethal distending toxin, which then damage vinculin protein on nerve cells. So this is a very, very condensed and abbreviated version of what actually happens in great detail, which is in previous presentations. So also damage to the migrating motor complex can occur from Lyme disease, C. difficile, inflammatory bowel disease, scleroderma, diabetes, Ehlers-Danlos syndrome, which is a connective tissue condition, and quite it's not that uncommon as I previously thought. It's actually 1 in 10,000 autosomal recessive. It's an autosomal recessive disorder found in 1 in 10,000 people. So it's on par with celiac disease. So it's definitely something that we should include in our differential diagnosis as to underlying causes of SIBO. Now, hypothyroidism does reduce esophageal and gastric motor activity and cause gastrointestinal dysfunction based on that. So it does slow the movement through the small intestine. In terms of drugs, opiates and recurrent antibiotics are in this category, as well as surgery and injury to muscle and nerves. Then we move to the autonomic nervous system dysfunction, where we see really sympathetic dominance. And this is something that's very commonly seen in our practices, where people are very, very anxious and have a very strong sympathetic tone. One word about inflammatory bowel disease, just as an aside, is that, well, not an aside, very germane to this point, is that it really causes this transmural thickening of the gut wall, which then impairs the migrating motor complex. So that's the mechanism of action of how it impairs the migrating complex. Now, this is a great little video that I want to share with you that will kind of give you a visual of what happens here in the small intestine. So this is a fluoroscopy where we're seeing a bolus of dye moves through the small intestine, and you can see these very distinct waves that occur in this video, and these really are very or demonstrate very clearly the effectiveness of the migrating motor complex. I thought that was very cool, and thanks to Alison Seebecker for alerting us to this. You can watch it yourself if you go to the link up at the top of this slide. And this is, I believe this is video number 15 on that website. So I always like seeing these things in action. Okay, so altered anatomy or structure causes bacterial clearance to be blocked or causes retrograde migration from the large intestine. And top of the list really are adhesions, which we'll talk about in our next slide. These also include partial obstructions and strictures are often seen in inflammatory bowel disease, but also, of course, tumors. But this is not the first thing we think of when we have a SIBO patient. Good to always consider these in our older patients. Also, compressions and twists can occur. This is not something that would be at the top of my list necessarily, but it's important to put it here to bring it to your attention. Again, inflammatory bowel disease strictures. So people out there that are treating patients with Crohn's disease or ulcerative colitis, just be aware of this, that there is very often a SIBO component to these patients. And this is more towards the end of tonight's presentation, will I be talking about IBD in particular. Also, the removal of the ileocecal valve, which commonly occurs in IBD surgeries, and volvulus, which is a congenital obstruction caused by twisting of the stomach or intestine. Again, not something that you're going to see that much, as well as superior mesenteric artery syndrome. It's just good to complete the list. And also non-draining pockets. So these are more post-surgery blind loops, and also small intestinal diverticula. These are diverticula that can also occur in the small intestine. Typically, we see this more in the large intestine, but I have often reviewed colonoscopy reports that do mention the presence of small intestinal diverticula, and these are just little eddies in the river of the small intestine, and they can just cause an area of stagnation where bacteria can grow. So let's have a closer look at adhesion, strictures, and obstruction, and consider these with the following common surgical histories. I mean, all of us see this every day in our practice, where a woman comes in, has a history of endometriosis, and therefore has had one or more laparoscopies. Woman who's had a C-section or an episiotomy. Anybody that's had an appendectomy or a bowel obstruction repair, or had their gallbladder taken out, or had back or hip surgery, had a hysterectomy, or more drastically a gastric bypass. So really, these are people that we see every day in our clinics. So have a look at these graphs, which are actually from the Clear Passage website. And Clear Passage is a wonderful organization or company in Colorado that I've mentioned last year that specifically treats adhesions and strictures non-surgically. So a little bit more about that later, but you can find these on clearpassage.com. So here you have, I'll try to be very careful with my mouse. So over here we have the small intestine really widening due to these adhesion formations between these loops. Again, could be anyone on this list that has had any of these surgeries could present like this with SIBO due to adhesion. So I definitely pay a lot more attention to adhesions these days, and anybody that's had ongoing problems or SIBO that's not resolving or relapsing frequently, I send them straight over to Alyssa Tate in Brisbane and have her work on them for me to see if that makes a big difference. And I've had some pretty amazing reports back. This is another example down here in the bottom right-hand corner, where you can have adhesions really almost completely encirculate the small intestinal loop. So you can imagine the difficulty that food or chyme rather would have getting through here. So what that would cause is just an area of stagnation. So really think about that when you see your patients and that have any sort of scar. If you do abdominal exams, just look for scars and laparoscopy scars and C-section scars and so forth. One study in the Lancet actually looked at 30,000 patients with a history of open abdominal or pelvic surgery, and 35% of those 30,000 patients were readmitted for adhesion surgery after they had completed their initial surgery. So this is not a small matter when it comes to SIBO. Other conditions that can cause adhesions spontaneously are infections like pelvic inflammatory disease, a ruptured appendix, those types of things. Also just general inflammation. Of course, SIBO, as I've just mentioned to you, is top of the list in terms of digestive causes of inflammation. And endometriosis is in that category as well. Also inflammatory bowel disease. These are all conditions that can increase inflammation and therefore scar formation in the intestinal tract. Also trauma, falls, car accidents, those types of things, and radiation therapy. And you can get more information on this topic at clearpassage.com. I think there's also a really wonderful little video that Larry Wern posted there for practitioners to just do rudimentary abdominal exams to inspect for scars and adhesions. Okay, so altered physiology is really our realm in terms of natural and integrative practitioners, where we often deal with hypochondria and altered bioflow, deal with the fallout that comes with proton pump inhibitors. We also deal with frank immunodeficiency and the microvilli damage of leaky gut. So this is very well understood by us, that if you don't have enough acid, you're not going to kill the bacteria very well. And if you don't have bile coming into your small intestine, then you're much more likely to suffer constipation, and that can cause a slow transit, which causes stagnation and so forth. So I think we all feel very comfortable with this category of underlying causes. So important considerations is that SIBO is associated with chronic relapse. And you can see from the adhesion slides that it's clear that if you kill bacteria and you don't really deal with the cause of this bacterial overgrowth, then that relapse is likely. If you haven't gotten rid of the kink in the garden hose, it will just recur. So, and that's not always because of adhesions, of course. All the other categories that I've mentioned are just as important, but I think that this is something that we must consider, is to have somebody be assessed for adhesions. So the more the practitioner understands and treats the cause, the more relapses are minimized. So ask your patients about abdominal surgery, ask them about if they've had any sort of condition that involves endometriosis or any inflammatory condition like that. If you know they have hypothyroid, then you might want to also consider improving their digestion. And always, always ask your patients about a history of gastroenteritis and if they've had their digestive symptoms since this case of gastroenteritis, because that's probably the strongest causative factor for SIBO, known as post-infectious IBS, which is, of course, SIBO. And so these patients may have to stay on prokinetics indefinitely because this is an autoimmune condition. I've mentioned last year that there is a blood test that's available in America called the IBS check that tests the blood for antivinculin antibodies, so direct antibodies to the migrating motor complex, and which of course are high after gastroenteritis, or if a patient has SIBO due to that. And this is still not available in Australia because of the sensitivity of sending blood. So that's not yet on the horizon. So Dr. Scarpignato, who is an Italian gastroenterologist and professor of pharmacology, talks about that anyone who's had a history of proton pump inhibitors has a high incidence of relapse. So this is even after they've discontinued these PPIs. Also understanding that in some cases SIBO really is a condition, or the cause of SIBO, the condition that caused SIBO cannot be cured, and these of course include genetic conditions, advanced scleroderma, perhaps a surgical damage to nerves, and in these cases you may want to advise your patient that their condition can be managed, meaning that you might have to go through cyclical courses of antimicrobials and find a prokinetic that really works for these patients. All right, moving into SIBO treatment in pregnancy, lactation, and pediatrics. And this is something that I get actually asked a lot, and especially around breath testing, because testing a 2 or 3 year old with controlled breathing is just very difficult. So, but as it pertains to treatment, Dr. Siebecker did an excellent gave an excellent presentation what is safe and what is not considered safe. So what we use, what is really safe to use, is allicin. Allicin is of course the active ingredient in Allimax. I've been talking about Allimax for years now, which is our star performer when it comes to methane dominant SIBO. Also for those of you who can prescribe low dose naltrexone, this is a medication that's often used in SIBO circles as a prokinetic with varying results. It's not the best prokinetic I've heard, and it's usually used in those that have a concomitant autoimmune disease because it also is typically used for that, but it is safe to use in pregnancy. Also Iberogast, which is a product that's similar to my bitters formula that has quite a bit of research, and I'm sort of like, you know, I think it's a great product. I see sort of very mixed results with Iberogast as a prokinetic, and I hear that also from other practitioners. You can use ginger, and of course ginger, we often use this as it's also wonderful for nausea of pregnancy. You can go up to pretty high doses with ginger. And then not recommended is berberine, oregano, neem, cinnamon, and Modal Pro. These are all products I've spoken about before in terms of SIBO treatment. And then metronidazole procalcipride, which is Resolor, a prescription prokinetic. These are all category B, which means that it's animal studies. They have not really been tested very well, or they don't really understand yet if that's safe or not. Erythromycin, I will say, usually as a prokinetic, the dose is only 50 milligrams. And so that is a pretty safe bet to use as a prokinetic. Rifaximin, unfortunately, is category C in pregnancy, which is animal reproduction studies have shown an adverse effect on the fetus. And there are no adequate and well-controlled studies in humans, but potential benefits may warrant use of the drug in pregnant women. So practitioners beware. And then category D is neomycin, that you definitely don't want to use that in pregnant women. In lactation, the safest antimicrobials are allicin, rifaximin, and neomycin. So rifaximin, that's understandable. It usually is not all that well absorbed, so you're not going to have that very much of it left in breast milk. The safest prokinetics are low-dose naltrexone, Iberogast, and ginger. This NJ is me. I've used bitters safely at 6+ months of lactation, and the formula for my bitters is in the Foundation's webinar or presentation, so I'll review that. That's a great little formula if you haven't used it before. What's safe, of course, is still allicin, Iberogast, ginger, and Alison Siebecker has used berberine and oregano at 8+ months of lactation safely, so that's another consideration for you. What's not recommended is berberine, oregano, neem, cinnamon, and Modal Pro. And then low secretion in milk is rifaximin. Neomycin is kind of insignificant, as well as erythromycin, and then there are really no human data on procalcipride. and then metronidazole is secreted in milk, so it's not all that great. And I don't recommend metronidazole really ever. In my book, it is not a very good approach to SIBO. So pediatric doses or recommendations are listed here. So these are all just smaller amounts of the adult dose, but you can use rifaximin, about 30 milligrams per kilogram for 7 to 14 days, or 200 milligrams 3 times a day seems to be a good dose. And so just have a look through the rest of that, or refer back to it when you have a patient. It's all listed there. All right, let's move on to biofilms. So biofilms, this is a topic that's come up before, and I think it was at last year's, or maybe even the first SIBO Symposium, where there was not really a consensus about whether or not we should recommend biofilm treatment. Of course, it makes sense that most infections have the capability, or organisms have the capability of producing a biofilm, but the practitioners that I've spoken to and the presenters, they really weren't seeing much of a muchness in terms of whether using one or not using one. They sort of had the same outcome. So I had sort of dropped it for probably the last year, and then I sort of picked it back up again in the last 6 months, and kind of, you know, I mean, again, it's one of those things that you have to sort of experiment with. But Dr. Ruscio gave a great presentation on biofilm, and for those of you who go to the Metagenics Congress, he's actually going to be presenting there at next year's Congress, and this will all be about gut and digestive issues. I'm really curious about that. But anyways, he talked about that biofilm formation is really found in most subacute and chronic bacterial infections. So it really makes sense that we would see this within the context of SIBO. So antimicrobial agents can actually become trapped within the biofilm and then be inactivated by the enzymes that are released by these bacteria or organisms. So that's a bit of a scary thought. You're giving your antimicrobials and they're being totally rendered inactive by these enzymes. So it makes sense that we do want to consider that, especially if you have a patient that comes in and they've been dealing with SIBO for 20 years or so. If they've just had it since a year, you could probably just start with your antimicrobials and then move into using a biofilm disruptor later on if they're just not moving with these antimicrobials. That really makes sense to me. So the other issue is that, and of course this is very germane of what we're seeing now with antibiotic resistance, is that biofilm is sort of a little breeding ground for gene transfer and increased expression of resistant genes. So it's something that we do want to address. And then biofilm bacteria can also decrease their growth rate, making antimicrobials less effective. So they're very, very elusive little critters. So this is an interesting quote that is from a particular study, mucosal flora in Crohn's disease and ulcerative colitis, and they talked about that inflammatory bowel disease can be viewed as a polymicrobial infection that is characterized by complex bacterial biofilms on the epithelial surface. I thought that was a pretty bold statement and very, very interesting in terms of IBD, but certainly it's something to consider also in IBS, which of course is SIBO. So also Candida can create biofilms, and these may be present in more than 65% of all bacterial infections. There aren't any specific studies on Methanobrevibacter smithii, but there was one that reviewed several species of Methanobrevibacter, which is in the Archaea group. The Archaea are not really bacteria. They're sort of a little breed for themselves, and they're also the extremophiles. So we find them in many different niches on the planet, actually. One of them happens to be our gut. So the treatment, as per Dr. Ruscio, is NAC, and of course we know that. We've used that for some time, and I think there's some good considerations. I do think that if somebody has hydrogen sulfide dominance, which of course still to this day we cannot test by a breath, there is potentially something coming up on the horizon, but it's too soon to say. But if you have a patient that is flatlining on a breath test, meaning that their hydrogen and their methane are fairly consistently in the zeros and ones, it's likely that they have some element of hydrogen sulfide in their system if they are symptomatic for SIBO and complain of very, very foul gas that smells like rotten egg, very classic for hydrogen sulfide. And so there's some concern, and actually Dr. Lisa Sheva pointed this out, and she has, she's one of the SIBO presenters, but she also has a SIBO discussion group for practitioners on Facebook. And she pointed this out, that using sulfur-containing amino acids and foods may actually provide a substrate for hydrogen sulfide. So it's something to watch. If that gas gets intensified or worsened, then you might want to back off of NAC or N-acetylcysteine. Also using natto, lumbro, and serrapeptases. I've used serrapeptase very successfully with biofilms in the past. Also proteolytic enzymes, of course, which are any number of enzyme formulas that you can use in between meals. And then also chelators for metals and minerals, and that's because metals and minerals tend to be concentrated in biofilms, oddly, but that is what happens. And so using chelators of that might be helpful, and you can use a number of different chelators of that. This is sort of outside the scope of this presentation. Maybe in future presentation we can take this up again. Also a number of well-controlled studies indicate that probiotics, particularly lactobacilli species, suppress candida growth and biofilm development in vitro. So this is always a difficult assessment to make in clinic, but it's a good consideration. I've always dosed my biofilm disruptors about 20 minutes to 30 minutes prior to dosing the antimicrobial, but this does not appear to matter, so that's good. People can just take everything at once. And there's just a note that in previous webinars I've reported that there was not much benefit, but I think it's really worth considering in your chronic patients, and I'm certainly going to use more biofilm this year, and will report back to you next year. Okay, now we're sort of moving into really uncharted territory of looking at the prevalence of SIBO and Lyme disease, which of course Lyme and other stealth infections appear to be on the increase and spreading, and are believed to be pretty much on every continent, yes, including Australia. And I know that most of you know that the general convention seems to be that Lyme does not exist in Australia, but borreliosis is definitely on this continent. And people are traveling and are exposed to other tick-borne illnesses abroad, and that doesn't magically disappear when you re-enter Australia. So this is something to consider. Again, I'm not a Lyme expert. Have definitely studied and researched a lot, but I wouldn't say I'm a Lyme expert. I think you need to really be somebody who focuses on that almost exclusively to be one. So, but Dr. Babar gave this very interesting presentation. He is a gastroenterologist practicing in LA, and that alone is interesting, that he's a gastroenterologist talking about Lyme disease. And he talked about, it was a very lengthy presentation, but I'm just summarizing that the top 10 symptoms of tick-borne disease infection is bloating, right? 76% of patients report bloating. Also tiring easily, weakness, of course, we see that also with our SIBO patients, anxiety, abdominal pain, sleeplessness, constipation, food intolerances, irregular bowel movements, and weight loss or weight gain, as well as joint pain. So these are very common symptoms that also appear in our SIBO patients. So he talked about that in his clinic, has seen basically most of his Lyme-affected patients also test positive for SIBO. And in this one study that he talked about in his in-clinic study of over 200 patients showed a SIBO positive rate of about 65%. So those of you out there that are specialists in Lyme or borreliosis and co-infections, you might want to consider testing them for SIBO because it's very much easier and less costly to actually test that, because we know how costly that can be to be chasing up these stealth infections. So Lyme commonly affects the autonomic nervous system and the enteric nervous system, and of course the autonomic nervous system is divided into the sympathetic, or the fight or flight, and the parasympathetic, which is rest and digest, just generally speaking, and the enteric nervous system. So this is just a small graphic looking at the central nervous system that is connected to the peripheral ganglion, and then the target cell. So it really talks about that Lyme and co-infections do infect these small fibers that are connected to the enteric nervous system. So this is a cool graphic that shows how on the left here we have sympathetic outflow, and on the right we have parasympathetic outflow. And what you can see here is the great big vagus nerve, which comes from the brain stem, one of the cranial nerves, of course, and pretty much innervates all aspects of the digestive tract, except for the rectum, which is directly innervated by the parasympathetic nervous system. So this is an important part for those people who are trying to reset their vagus nerve with all sorts of exercises. But if they have a lot of issues with constipation and in the rectum, this might not be really involved with the vagus nerve. But so the point being here, as it relates to Lyme and co-infections, is that those conditions or infections really are focused on small fibers, and which are often seen in the small intestine and in the digestive tract in general. So you can have an infection and it being affecting the migrating motor complex. So small fiber peripheral neuropathy is a type of peripheral neuropathy that occurs from the damage to the small unmyelinated peripheral nerve fibers. And these fibers, categorized as C fibers, are present in skin, peripheral nerves, and organs. And mechanism of injury to the nerve through Lyme, in terms of neuroborreliosis, is either direct bacterial invasion or mediated by the body's defense systems, so the cytokine-mediated damage or autoimmune-mediated, as we saw also with antivinculin. This is another autoimmune component to this. So this is just, very, I think, important for us to understand as far as another possibility, and if systemic symptoms are not improving, you might want to consider this. I actually have 2 patients right now that one did test positive for a whole plethora of infections, and another one I'm thinking of testing because what I find is that they tend to get worse when you try to improve their adrenal output. And that's, this is again perhaps beyond the scope of this lecture, but it's very classic to have a flatlining adrenal response when you have stealth infections, as the body tries to protect itself and the hippocampus from ongoing cortisol onslaught, as that causes hippocampal atrophy. So it's a really common presentation with these chronically ill patients to see a flatlining adrenal response, and if you then go in and try to increase that response in opposition to what the body is doing, we sometimes can see a worsening, and that even just with these last 2 patients I've seen that borne out. So this is just an interesting side note if you are specializing in chronic illness. So finishing up on the Lyme. So really what we're looking at, and consider Lyme as an underlying issue, or let's say borreliosis or chronic stealth infection, you can see symptoms of autonomic dysfunction due to this small fiber invasion, and this would be excessive fatigue, lightheadedness, blood pressure fluctuations. We often think of that as orthostatic hypotension, hypotension. Also distension of the abdomen and gastroparesis and constipation. These are, of course, our SIBO symptoms, gastroparesis being slow gastric emptying. So this is where patients complain of that they feel full hours after they've eaten, even if they do take hydrochloric acid. Sweating issues and also dry mouth, rapid heart rate. These are all symptoms of autonomic dysfunction. And lastly, this is just another little pearl that he presented with, is patients with treatment-resistant gastroesophageal reflux disease, or just reflux, and small fiber neuropathy. And what he talked about is that the fundus of the stomach loses its what's known accommodation ability, meaning that its ability to stretch when food is filling the stomach, and therefore this constant pressure in the upper gut. Now sometimes that's just, I find that a lot of times people's diaphragms are really very rigid and stuck and they're not breathing properly, and that gives that feeling of fullness as well. But that doesn't usually or necessarily cause a lot of that reflux that we see, or that can be seen with this treatment resistance. So consider that also, that if you're treating somebody for gastroesophageal reflux disease and they've had gastroscopies and they can't find anything, and the lower esophageal valve is, or sphincter is intact, and really nothing can be found, and they fit the bill for all these other chronic symptoms, that you might want to consider that as well. All right, moving on to SIBO and inflammatory bowel disease. This is just a one-slide little summary. These are presentations by Dr. Gary Weiner and Ilana Gurovich, and talked about that SIBO appears to be the IBS within the IBD. So we all understand that inflammatory bowel disease, of course, is a very, very different condition than IBS. It's a much more sinister and inflammatory driven and very destructive. So, and a lot more complicated, I'd say, than IBS for sure. And so, but what we see is that many patients with IBD do have concomitant SIBO. Many patients that have that, and probably SIBO causes periodic flare-ups of their symptoms. So the incidence of SIBO in IBD is much increased. I've listed a couple of studies down below. And the risk factors which contribute to SIBO in inflammatory bowel disease are any issues around the ileocecal valve. And as I've mentioned before, many patients with IBD have the ICV resected, meaning that there's nothing there. So your chance of retrograde migration becomes much greater in these cases. But it can also be scarred and inflamed and kept open or stuck open. So it's really important to consider that if you have IBD patients that have had bowel resections. So again, I've mentioned it before, that transmural thickening impairs your migrating motor complex, which causes, of course, small intestinal stagnation and therefore SIBO. And these patients are much more at risk for adhesions and strictures, and also the oral cecal transit time is impaired in ulcerative colitis. So consider testing for SIBO as part of your routine workup for patients with IBD. Okay, so moving into the presentation that I actually just gave at the SIBO Symposium. This is the new biphasic diet. We're going to talk about some new herbal considerations, and then I'll finish up with an update on rifaximin, which was actually not presented by me, but by Dr. Carmelo Scarpagnato, who is truly an expert on the, he literally wrote the book on rifaximin, but more about that a little later. So let's look at the biphasic diet for a moment. Now, this is a diet I've devised based on Dr. C. Becker's diet, but also just other types of protocols that I've sort of incorporated into this treatment protocol. And what I initially wanted people to do, or advised people to do, was to start antimicrobials from the get-go. And that is the big change here, that the biphasic diet has gone under some revision. It's a beautiful handout that you can download from the website and give to your patients. I've removed all of the references to other treatment products, so it's really just talking about the diet itself. I've basically revised it also because general SIBO diet plans can be very confusing and highly variable. So this is a very distinct and very, I think, elegant way of treating your patient. And if you are somebody who is not really familiar with this, I really advise you to check it out, because I often see patients that were told to just Google FODMAP diet on the internet, and that unfortunately is not a SIBO diet. It's part of a SIBO diet, but it's still going to cause flare-ups in my experience. So the other issue about SIBO is that, of course, patients often need very customized approaches because they have particular digestive deficits or potentially suffer from other intolerances like histamine, salicylate, or oxalate intolerance. So we'll talk about that in a moment. And also often suffers from malnutrition. So where do you put in all of these different supplements is sometimes a good question. So what we've done now is that this new approach allows for a very sequential treatment protocol. So what we've done is that phase 1 is now renamed in the classic 4R sort of functional medicine style, reduce and repair. So let's say a patient comes in, you start them on phase 1, which is basically reduced fermentable starches and fibers and therefore bacterial fermentation. You also might want to give them some repair for their intestinal inflammation or brush border enzymes or digestive support. So they start with the very restricted diet and maybe a product that includes glutamine or enzymes or bitters or other digestive support. It typically starts out with a very restricted food plan, and then patients, as soon as they start to improve, and this can be a self-monitored process, I usually say, look, start over here, and this becomes more clear on the second page, or with my next slide. Start with the restricted, but as soon as you improve, you can move into the semi-restricted, which is still phase 1. So it's very, very helpful to tell patients that, and it makes it very easy and easy to follow. And this is usually done for about 4 to 6 weeks. And the purpose of that, and why you haven't used antimicrobials yet, is you're really giving the body a chance to repair itself a little bit before you're using antimicrobials, because usually if we have a case of SIFO or small intestine fungal overgrowth along with SIBO, you're going to get a lot of die-off if you starve them and kill them, and then you're also adding in your antimicrobials. It can be quite intense. So I found this to be a lot gentler, and by simply reducing fermentable foods, they're already starting to reduce bacterial numbers, so that when you move in to phase 2, which occurs about 4 to 6 weeks after you first put them on phase 1, then it's just not as harsh for patients. So I'm really liking the new approach. It was also born out of this idea that when we start to actually use antimicrobials in phase 2, we're feeding them a little bit, because phase 2 is not as strict as phase 1. So phase 2 is remove and restore, so you're removing bacteria with antimicrobials and you're restoring motility. So what does it actually look like? Looks a lot prettier than it did before. And so the blue column is where you start your patient out with, and it is very restricted, as it always was. If they improve, sometimes even within a few days or a week, so before they have had a chance to return, they could move into the green column. Or you can tell them also, you can kind of move between blue and green until I see you again. Very easy. The same old as before, the avoid category is still there, so there's pretty much, if it's not on this sheet, they shouldn't even consider consuming it, or they should not bother you with emails. This is what I usually tell them. It's like, if it's not on the list, you're not allowed to have it. It's as simple as that. So moving on to, this is still phase 2, this is the grains and legumes and soups. So just have a look at that. When you have a chance, you can download it from our website when you log into your practitioner account. And then phase 2 is a little bit more generous, where we have a bit of yogurt if they can tolerate dairy, and cheese, and all of the vegetable categories are in greater quantities, and the return of grains if you'd like them to, with rice and quinoa and so forth. And even rice cakes and rice noodles are now allowed. And so moving on to the last page on the handout, we do have some recipes that are attached to the handouts that gets patients started. But what we now have, which is wonderful, is Rebecca Coombs' 2 cookbooks that are beautifully presented that give your patient a plethora of ideas for breakfast, lunch, and dinner. And this is based on the Biphasic diet protocol. And the link is at the top. You can peruse through these, or go to thehealthygut.com.au and have a look around. They're really beautifully presented. And so this is often a complaint we've heard from patients, is like, I don't know what else to eat. They've already come in very restricted. So this is a very, very helpful tool. So moving into food reactions, so chronic SIBO very, very often presents with other food reactions, so beyond just dairy and gluten and all the typical things that we expect in chronic digestive issues, but more related to histamine and salicylates and oxalates, which are probably the most common seen in my practice. I can also add amines to that, and it gets very, very complicated when you have to tease out all the different layers of food reactions. And this will be the topic of my presentation in during the SIBO Summit, is I'm going to be talking much more about salicylates and histamines in particular, because it gets complicated, but you can see dramatic improvements with your patients if you start paying attention to that. But again, I'm giving you sort of an idea as to what to consider. It's certainly not every patient, and the moment you remove salicylates, it becomes very complicated for your patient to find anything to eat, because salicylates are very, very ubiquitous. They're found in many, many foods. All right, we've also have a paragraph on each of these in the Biphasic diet handout, so your patient is made aware of that and is asked to talk to you if they suspect certain foods are problematic for them. So histamine is a biogenic amine. Just very briefly, it's naturally high in certain foods, especially aged foods, so this is why some people don't do so well with bone broths, because it's an aged food. But the classic symptoms of histamine intolerance include headaches, bloating, cramping, insomnia, itching, and hay fever-like allergies. I'd also say hives, which is of course related to the itching, but hives in particular is more histamine related. Histamine is also found in spinach and fish, especially tinned fish and meats. So one big issue around histamine as it relates to SIBO is that because hydrogen and methane gases cause a degradation of the microvilli and brush border, it also therefore leads to a reduction of diamine oxidase, which is the primary enzyme responsible for the degradation of these foodborne histamines. So even if people never had a problem with histamine, with SIBO they can develop a problem. Very important. Salicylates, just briefly, are natural plant substances which help the plant defend itself. So this is very commonly found, and most of the time, most of us have no problems with salicylates. They are toxic to everyone in very high doses, but when you have SIBO, that sensitivity threshold is much lower, and so you can develop reactions, and it's important as a savvy practitioner to understand that. I work with a really talented nutritionist here in the Northern Rivers, who I'm referring more patients to, that understands how to nut out these different sensitivities, and it just helps to streamline the process for my patients. And I recommend that you consider that with somebody who's very savvy in your area that can help you, because honestly, in the context of my visits, there's so much to talk about. I often just don't have time to go into great details with their diet, unfortunately. I have so many other things to cover when I see my patients. But anyways, you might, so that might be helpful for you to educate yourself a bit more about this. So the range of salicylate content of food varies. In the biphasic diet, it's highest in nightshade vegetables, tomato, eggplant, capsicum, chili, as well as radish, zucchini, berries, avocado, coconut, and olive oils, right? Everybody's on a coconut craze. So those that don't tolerate coconut, consider this. I mean, there's lots of other reasons, but coconut is, I think, to some extent being overconsumed in some cases. Oxalates are a little bit of an outlying sensitivity because most of the times you see more joint pain. You see it's obviously classically related to kidney stones, but also in vulvodynia or vulvar pain. So that is something I often remove from patients' diets when they present with that. Found very, very, very high levels in leafy vegetables and other plant-based foods. So it gets really boring very quickly if you remove a lot of these food categories. So be careful with that and just be a discerning practitioner. One of the reasons why we see more issues with oxalates is because humans actually lack the enzyme needed to directly metabolize oxalate, and it's usually eliminated by oxalate-degrading bacteria called Oxalobacter formigenes, and in many patients this is just missing due to very high antibiotic history. So you can use Lactobacillus paracasei, L. plantarum, and other Lactobacillus species as they show some promise in helping to reduce oxalates and help to sort of manage that a little bit for your patient. Oh, was not finished with that. So the range of oxalate content varies, but high oxalate foods on the biphasic diet are almonds, spinach, silver beet, beetroot tops, and rhubarb, and quinoa, and cacao. So, you know, it helps to know if your patient is reactive to these foods that it might actually be due to oxalates. Just a caution with the SIBO biphasic diet is that you know, you don't want to have this go on for an indefinite amount of time. So typically with FODMAPs, you know, I feel like we have a responsibility to tell patients that this is not a healthy diet for long term. Why? Because you are starving the microbiome. These fermentable fibers are crucial for a healthy microbiome. So you're really just restricting it for the purpose of reducing the bacterial load in your patients. The orthorexia is really a medical condition in which the patient systematically avoids very specific foods that they believe are harmful. And there are elements of orthorexia in some patients that have severely restricted their foods. But of course, we must understand that it's not that they believe that they have a reaction. They really do have a reaction, just like with Pavlovian, when Pavlov rang his bell, dogs didn't just think they salivated, they really did salivate, meaning that they trained their own bodies to respond in a certain way. And so that also happens with very, very drastic food restrictions, and some of that is clearly due to leaky gut and clearly due to the fact that these patients have very severe digestive disorders. No one denies that. But I often tell my patients that it's normal to have a bit of if you're only eating 5 foods and you've only eaten 5 foods for a year, it's normal to have a bit of a reaction when you include anything into your diet, because you have favored the growth of just a very limited number of bacteria in your microbiome for a long time, and anytime you add anything else in it, you'll have a little bit of a flare from other bacterial growth. It's normal. So that helps to overcome some fear. I also ask people to have a moment of a little intention setting around mealtime, about saying this food is not going to harm me, this food is good for me. So it's really about a retraining out of that fight or flight response around foods. It's also important, like I said, to give your patient a time frame so that we understand that this diet is not a forever thing, because it's so crushing, I believe, and I've seen it. People just are very upset when you tell them that. All right, moving into new herbal antimicrobials. I think I have to pick up my pace a little bit. So basically, antibiotics for SIBO. This is more for GPs out there that you do have a little bit of a, of a dilemma where I really personally only recommend rifaximin, possibly neomycin, but rifaximin does not seem to have an effect on the large intestinal microbiome. So it seems to be a very safe antibiotic, and for those of you who can prescribe that, it's a good idea for hydrogen producing bacteria. Not so great for methane producing bacteria, and definitely it will do nothing for SIFO, so you still have to consider using an antifungal. But other antibiotics that are sometimes used by perhaps less educated practitioners around SIBO, like metronidazole and stuff, I really do believe that you're sort of moving out of the frying pan and into the fire, because through the microbiome project and a lot of the research that's coming out, we're finding out that the devastating effects that we've seen with antibiotic use on the digestive tract, and this is certainly not news to any of us who've been in this field for a long time. We've talked about the importance of the large intestinal microbiome for what seems eons. So it's nice to be validated by science, but it's also important to understand our responsibility around the use of antibiotics. So the culprits in SIBO really are the gram-positive bacteria are the Enterococcus species. Also, Streptococcus and Staphylococcus as definitely there. So that's those are all the gram-positives, and gram-negatives are Proteus mirabilis, E. coli, Klebsiella pneumonia. Those are the most common gram-negatives. And then we have Methanobrevibacter smithii, which causes your methane production. Again, comorbid SIFO or small intestine fungal overgrowth is up to 63% of your SIBO patients. So please consider using an antifungal along with your conventional antibiotics if you are opting to do so. Of course, what we use for herbs are, one of the beautiful things about herbs is that they have such a wide range of action across a number of organisms. So very often our herbs will work beautifully for bacteria as well as fungi. I'll just I'm not even going to spend much time on this. I've talked about this last year, but this was a wonderful study done by Dr. Mullen at the Johns Hopkins University, showed that herbal antimicrobials are as effective as rifaximin for the treatment of SIBO. So don't think you are missing out if you cannot prescribe rifaximin. This is basically a snapshot of the 4 different compounds he's used, and they all came from one company in America, and those are the ingredients in each one of these formulas. So none of them were ever used in isolation, but we see a lot of old friends, as I call them, on this list. We have Podiarco, which of course is often used for fungal infections. We have Artemisia, we have Sida, which is a wonderful antimicrobial that I'm starting to use more. All across here you see traditionally used antimicrobials. So the herbal antimicrobials that I've spoken about in the past, very well established. Berberine containing herbs are clinically well or very, very effective. So this includes the philodendron, Mahonia, Acropholium, Coptis chinensis, Berberis vulgaris, Hydrastis. So Mahonia is actually Oregon grape, which is available to us here as well. All of these we can get in Australia. These are effective against E. coli, Streptococcus, Klebsiella, and Candida species. They're poorly absorbed, so perfect for local infections. And they also have this sort of tonifying effect, but that can also give them this very classic, have patients complain of side effects of nausea. The garlic is not just any old garlic, because garlic also is a high FODMAP food, so you must source a garlic that's actually very high in allicin or alliin, which is the active ingredient, and I classically use, again, Allimax. Very, very effective for lowering methane in your patients. and then also essential oils of oregano, cinnamon, and thyme for both methane and hydrogen. So this is a classic reduction of hydrogen with using berberine plants. So on the left here we have control 20 minutes, 40 minutes, 60 minutes. So here's a patient that has consumed lactulose after the baseline. And what we see here is at 60 minutes he or she is positive with a rise up to 20 and then very, very positive at 80 minutes. And so after about 4 weeks, what we see here is the outcome of berberine containing prescriptions. On the left here is not the highest that we've ever seen at all, but we do see very nice reduction with just berberine in both methane and hydrogen. So sometimes you get lucky like that, but very effective indeed. Garlic and methane, we see very classically a reduction of about 30 parts per million per course. And so here's a patient that started at baseline at 35. Arguably, they may not have actually prepped very well, but certainly throughout the treatment, they're still high. And then after treatment, you see pretty good reduction in that, pretty classic reduction. So our plants certainly do work. So other phytomedicines to consider, my new love is pomegranate. Again, what I'm saying is try your old and tried and proven remedies first. Use your berberine, use your garlic and all that. But if you retest and they have not adequately moved, then consider using a biofilm and perhaps another round of your favorites. And then if that's not moving, use to these new herbs. So pomegranate is a wonderful herb that is very effective across a range of organisms. I've listed them all here, all classic SIBO organisms. Also very effective for candida, as well as giardia and blastocystis and entamoeba, as well as cryptosporidium. I've certainly used it for blastocystis very effectively, so it's something to keep in your medicinary. It enhances also the growth of lactobacillus and bifidobacterium, so this is always a wonderful thing if your herb is actually doing more good than harm. And the therapeutic dose is listed here. So this is in a liquid tincture. I have only used liquid tinctures with pomegranate, so I cannot attest to the effectiveness of extracts of or active constituents, basically just active constituents in an extract. I have not used that, but the tincture works beautifully well. So Artemisia annua, old friend of ours in the naturopathic repertoire. So we classically use that for staph, strep, and gram-negative bacteria, very effective there as well. It's also traditionally an antiparasitic against toxoplasmosis and horrible diseases like liver flukes and malaria as well, like Plasmodium falciparum. I can't remember the last name there, but Plasmodium or the malaria bug. And so a number of very, very strong effects here against these parasites. One of the nice things about Artemisia is that it's also very immunomodulatory, so it inhibits nitric oxides and inducible nitric oxide and NF-kappa beta, which is of course an amplifier of inflammation. So this is a good one if you're considering an anti-inflammatory as well. Usnea is probably my favorite herb, perhaps of all times. It's because it really grows very, very well in the Pacific Northwest, but hey, I've got some here also on my property. It's a beautiful combination of a fungus and an algae, actually, or lichen, I should say. And so it's very distinct when you see it, and it's also very active against gram-positive bacteria, mostly gram-positive bacteria as well as fungal species. I've used it a lot for fungal species, and some gram-negatives, though it's not as strong for that. It also is an anti-inflammatory, and in one study it was actually more effective than non-steroidal anti-inflammatories and hydrocortisone, so that's quite impressive. And it also activates superoxide dismutase and glutathione S transferase to protect against damage in mucosal cells. So beautiful action across a range of effects here. Bidens is burr marigold, and this photo was actually taken by my husband before he took a whippersnapper to it on our property. It's an annual weed, and it has a very strong affinity for mucous membranes. It's an anti-ulcer and an anti-inflammatory. And Steve Buhner, who's a wonderful herbalist who's written several books about the use of herbs for as antimicrobials, antivirals, and he even has written a book about Lyme and co-infections. Very good for your library, definitely. And he talks about Bidens as one of the great antibacterial herbs, a great mucous membrane tonic and astringent, and very, very powerfully anti-inflammatory and strongly antibacterial. So in particular with resistant pathogens, it's a good one to consider, and it is also a systemic antimicrobial, so good to consider. It is just everywhere here in the Northern Rivers, so wherever you are, you might be lucky to have that weed populating your backyard. So it's great for gram-positive, Enterococcus, and Streptococcus species, as well as a range of E. coli. Pseudomonas, I've used it for lung infections with Pseudomonas. Pseudomonas is traditionally very difficult to treat and often very resistant for antibiotic treatment as well. So anything that you have in your armamentarium is always welcome in that regard. So put a little star next to that one. And also Candida parasilosis, which is a difficult Candida to treat. So Candida albicans is a little bit more of a easier one to treat in the family, and Candida parasilosis is a bit harder, so keep that one in mind as well. Benefits of herbal antimicrobial, I'm speeding up, I'm sorry. Herbal antimicrobial therapy is that you can really individualize your medicine to the patients. We've known that for a long time as naturopathic doctors and herbalists. You can add other herbs to your formulas that really strengthen and individualize this for your patient. You can also add minerals and homeopathics to your tinctures, and it is typically less damage to the microbiome. One thought I will say here is that there is no one-size-fits-all to SIBO treatment. You want to, I personally recommend using herbs before microbiome disrupting antibiotics. And also, if you are out there and you don't really have experience with herbs, just refer to somebody who does, or refer them to a medicinary that can put tinctures together if you do not have this sort of experience. Also, please only use herbal medicines from reputable manufacturers who test batches frequently, as there is a lot of adulteration and very nasty ingredients in herbs when they come from overseas very often, and you need a company that frequently batch tests. Also, rotate antimicrobial herbs to maintain effectiveness. I have found that to be the case, not as often as every few weeks, but certainly in between the retesting phases. This as a last word is do not use your low FODMAP diet or biphasic diet indefinitely. Now, very quickly, rifaximin update by Dr. Carmelo Scarpinato. Those are literally the 3 books that he's written, and he's used it. In Italy, they've used rifaximin for 30 years, so it's he's very well established over there, and definitely a lot cheaper, as I understand. So you want to. Last year, I said that you can retest with rifaximin after 5 to 7 days. That is incorrect. You need to actually wait 10 to 14 days after you've stopped using rifaximin before you can retest. He also mentioned cyclical treatment for chronic relapsers, and those are the relapsers that are perhaps relapsing due to one of the underlying causes, like adhesions that we've mentioned before. And what he talked about, cyclical treatment might be a week out of the month or so, which seems kind of intense, but you might just want to kind of rotate and then also use your diet approach and things like that. So the other bit here is that rifaximin actually is quite anti-inflammatory. So I'm sad I can't prescribe it. That's all I can say. It would be wonderful to have in my armamentarium, but I've got very great people to work with that I can do. Some noteworthy research just quickly here before we can start taking some questions is that this was something that Dr. Scarpinato also talked about, is that PPIs, the proton pump inhibitors, actually increases the incidence of SIBO, not just from the fact that you're not killing the bacteria as they're coming in through your food, but also the oropharyngeal type of microbes. We're seen more frequently in the small intestine where they're not meant to be when people have used PPIs. And also there was a much higher rate of relapse with a history of PPI use. And then even small courses of PPI use caused immediate changes in bowel flora. So I think that there is only really very limited number of reasons why anyone would want to maintain a patient on PPIs at this stage. He also talked about Lactobacillus paracasei F19 to supplement alongside PPIs if that's absolutely necessary for Barrett's esophagus or whatever that patient may have, which is arguably a reason to use it, but for any conventional standards dictate the use of PPIs in that condition. So you could supplement Lactobacillus paracasei F19 has shown less problems with their digestive tract when they've concomitantly used it. It's difficult to find. We don't have it in Australia yet, just letting you know that. But it's good to know in case it's coming very soon. The use of lovastatin to reduce methane. This was a study that Dr. Pimentel did that showed that, that lovastatin, and I'm not promoting the use of this, I'm just reporting people, using lovastatin actually interferes with the production of methane from methanogens, right? So this is just a thought, whether or not red yeast rice extract could have the same effect. We're starting to experiment, a few practitioners are doing that, and we will report back next year, and perhaps you can. Now, it's got to be very good quality red yeast rice extract, which of course is very much the same thing as lovastatin. Lovastatin comes from red yeast rice. So it is a natural, well, red yeast rice is a natural product, and if you have a patient that is just very recalcitrant with reducing methane gas, at least symptomatically, you could potentially consider red yeast rice. This is a study that looked at metabolic improvements in pre-diabetics by lowering methane. So this definitely has a role to play in obesity and metabolic syndrome. I'll let you read the study. And thank you very much. We're going to take some questions in a moment, but before I do that, please remember to sign up for the summit. The early bird ends August 1st. It will be recorded, so for those of you who cannot attend live, which of course is absolutely the very best to meet these legends in person, especially Allison and Jason and some of these other guest speakers that we have on board. So, but it will be recorded so you can video on demand it after I think a week after the summit. And then the SIBO Masterclass is now accepting enrollments. It starts September 1st. Also sign up for our blog posts where we post periodic research and announcements and so forth, and all of the different hashtags and Facebook accounts are there. So thank you so much for your time. I'm only 3 minutes late, but any questions that you have here, please post them in your in the little box that shows up. Emily, do you have any questions for me?
Yeah, there's some questions here.
Okay.
Read through those.
Yeah, I'm not seeing them. So if you could,
I'll come around. So.
Okay, let's have a look here.
So I think this first question from Michelle is to do with adhesions, so about the specialised gynae surgeons who do endosurgery, how would they remove the adhesions, or can they find them and remove them?
Yeah, but it's well known that even adhesion surgery is, I mean, the whole idea behind adhesions is that it's your body's way of trying to fix something it deems necessary to fix. And so anytime you go back in, you can trigger the same issue. So this is well known. That's why people with endometriosis and so forth have to go back repeatedly for adhesion surgery, and at some point, very often, they're not going to do it again because it's either too extensive or it's just not working. So I think that unless new developments that I'm unaware of, but to my knowledge at this stage, you really, it's not a great approach to have, unless there's really restriction of function that requires laparoscopic involvement where they laser off adhesions. That can be effective for a few years, but oftentimes you will have some return of adhesions. That's the long and the short of it.
Our next question also from Michelle. What's the Facebook site with the doctor on hydrogen sulfide? I think she's talking about Lisa Shaver.
Oh yes, so this is the, it's for practitioner discussion group, so if you're going to have to Google it, I don't know it offhand, but it's basically SIBO discussion group, and she kind of vets people to be licensed practitioners. If you are one, please join that group. It's very, very interesting. There's interesting cases being posted. It's an American group, so they very much talk about American prescriptions such as procalcipride and so forth. So, oh yeah, clinician SIBO discussion. That's the name of it. Emily just brought it up, and clinicians by invitation only.
Next one, also from Michelle, is chelators for metals and minerals. Would they be like the new activated zeolite froxinum?
Oh, the toxaprevent. Look, I'm excited about this product. I cannot endorse it yet. I've just started to use it for my sensitive patients. For those of you who don't know this is a product from Biopractica, and they have, it's a German product, I believe, that uses only one single ingredient, which is in the family of zeolite. It's not zeolite, but it's similar to zeolite, which is an absorptive substance. I cannot speak about this product since I've only just begun to use it. So it's early days in my book. I'm seeing some side effects from it that, you know, I mean, I always expect side effects in my highly sensitive patients. So that's perhaps not as surprising, but it's early days. I cannot say anything about this product yet.
Then Veronique, where would you test SIBO? I'm in Tasmania. Oh, through us, SIBO test.
Well, SIBO test, Veronica. SIBO, we're a testing facility. If you go have your patient order a test kit through, actually Emily will be in touch with you. If you don't know this, and Emily will be, yeah.
I'll contact you.
Yeah, so we're a testing facility, and this is what we do. We provide education, and we test your patient samples, and we send them back to you.
Yeah, at their home test, the short of it. So
yeah,
we send them anywhere.
we send them. We truly send them anywhere in the world.
Now from Zoe, do you think the other food intolerances generally come after the SIBO, or more often are they comorbid?
I think they're comorbid, Zoe, and one of the reasons for that is because, you know, when you have infection like that, when you have just rampant SIBO that causes inflammation, your likelihood of becoming more reactive just increases, and particularly with Candida, because Candida is so invasive. So, and you know, it's something that we don't really think about. We're just trained to think SIBO, but SIFO is just as bad. So, you know, I do see far more die-off symptoms with Candida also. So those people that just get terrible Herxheimer reactions are likely to also have a big element of Candida in there. And so you know, I mean, the thing is, when you specialize in SIBO like I do, you start to see very, very complicated and advanced cases. And I'd say almost all of them that I've come across, at least in the last year, have had some element of food intolerance. So which is really interesting, actually.
Now from Michelle, how would a visit of yours pan out for an initial and subsequent patient presenting with SIBO symptoms?
How would a visit of yours pan? I'm not sure what this means. I see patients via Skype, in person. I see them referred from practitioners. You know, I'm not sure how to, do you know how to interpret that question, Emily?
She may be asking what do you start off with in your consultation, and then when would you follow up with them?
I see. Okay, all right. Okay, so what I usually do is if they have not been tested for SIBO, clearly I will do that. And then I send them off, and I usually start them on phase 1. Now in the biphasic diet, which means that I start with my gut healers, and I usually give them something like, very often I give them trace minerals, and I give them also bitters. Now the thing with bitters is if you have a very, very intolerant patient, and let's say they are salicylate sensitive and you don't know that, they might react to herbs more than others, because herbs of course are plants, and plants have salicylates. So it's something to be aware of, and sometimes you have to start with drop-wise fashion and so forth. Or maybe you just give them apple cider vinegar before meals, because the acetic acid in apple cider vinegar is also very, you know, it's sort of like it's helpful in some cases to improve digestion. So it's varied, but I'd say in the last year I've seen more chronically ill patients than I did before, because I get a lot of patients referred now that have already been assessed for SIBO. So, you know, it's sort of like I'm kind of another resort, a last resort. I'm hopefully not, but it's just another way of looking at it, and every patient is very different. They have different presentations, but I'd say almost always I start with very simple nutritional aspects, and then see how they respond, and then inch my way forward.
What do you think of the ubiome DNA testing that is being advertised online?
I think it has a really good potential. Now remember it's only like, I think it's it's DNA testing, so it's PCR testing, I think, which means that you're not going to get counts of bacteria. You're only going to ever see, okay, well, this is likely to be what's in your neighborhood. These are the different species in your neighborhood. I haven't worked with it enough, to be honest. I sent mine away about 2 months ago. I've yet to hear back from them. So the turnaround time is not that impressive, but I think it holds really big promise, and I'm excited about seeing how it pans out in the long run. We don't have enough data yet with research to understand what these different species mean. Remember that only about 20%, if that, has been mapped in the Human Microbiome Project. 80% of the species we don't know anything about because they're anaerobic and can't be cultured out and so forth. So really interesting book. If you're interested in this, is Martin Blazer, Missing Microbes. I really loved reading that book. It's kind of for the layperson, but it gives you some good background as to the story of antibiotics and the research. He's actually the head of the Human Microbiome Project, and he's an infectious disease specialist. So good recommendation there.
Do you prescribe essential oils in neat form, as many online marketing, multi-level marketing companies do?
I do not have any. I don't do anything with multi-level marketing. That is my rule, my golden rule. I don't do anything with that. And so, but besides that, I mean, they've existed way before multi-level marketing in terms of essential oils. So no, I don't. I usually use that in combination. I have sort of favorite product. If you look at you know, Bactrex, the Metagenics product, which is a great product, really wonderful, has a lot of essential oils in it. So, you know, one of the problems with making oils neat is that if you use something like oregano or thyme or something, once that treatment is done, they will never want to look at another pizza again. Let me tell you that, because it's very strongly oregano and thyme. So I usually do kind of minimize the suffering to my patient. But if you have a comfort level with that, then by all means. And certainly there's argument to be made for really proximal SIBO and SIFO. So meaning that the closer you, even gastric issues. So using that on a more local level potentially without it having to pass through and be active in the small intestine. So that, I could see an argument for that, but no, I do not use neat essential oils.
Which company manufactures pomegranate? Is it Optimal RX?
Optimal RX does one.
Nutrition Care.
I think, yep, of course, Nutrition Care does one. And forgive me if you're on this podcast, on this show, and you're working for one of the companies, you might want to pipe up. But perhaps MediHerb I think the Herbal Extract Company.
Was it Gould's Pharmacy down in Tassie?
Oh yes, but that's Jason's.
That's Jason's.
Yeah.
Okay. Yeah. But anyway.
Yeah, I use Optimal RX, pomegranate, and Nutrition Care pomegranate.
Is Burr Marigold the same as Farmer's Friend?
Yeah, that's Cobbler's Peg. Yeah, I think AKA Farmer's Friend.
Can you discuss your approach with vegan patients?
Ren, I know it's difficult, isn't it? Well, I'd say the best approach to that is using the elemental diet, to be honest. And so the elemental diet, just in review, is not the same as using a protein shake or a green smoothie. It's definitely not the same. It's using a very distinct amino acid formula that typically does not taste very good, unfortunately. And the recipe for this is at siboinfo.com. This is Alison Seebecker's website, where she freely disseminates a lot of very good, great information and very, very helpful. And she has a recipe there. And the ingredients are ordered by from the patient, by the patient online. I think it's Claire Labs that gives the amino acid blend. I'm still in the process. Last year I talked about formulating my own because there's just such a paucity of these formulas here. I'm still in the works with that. There's also Integrative Therapeutics, which just came out. It's an American company, just came out with a fabulous tasting. I just tasted it at the SIBO Symposium. Tastes amazing product. They've worked really hard to improve the taste for this, and if you have a patient that can get their hands on that, it costs about $500. I believe it costs about $500, so it's not a cheap endeavor, right? But if you have a patient that is really quite ill and needs that nutrition, I think that's a good way to go. Other ways of doing that is, look, you're going to have to use some sort of protein supplement with this patient, and then then it's doable, I think.
Also from Ren, why are you using prokinetics after the bacterial clearing?
Good question. Well, it does not have to be this way. It's more for organizing your thoughts around it and for the sheer pill volume. Very often I overlap my treatment. I use the different prokinetics. Very often I use bitters from the get-go and don't stop it until I'm done. So it's usually your preference, and certainly if a patient is extremely constipated, I will use them before moving into phase 2.
Have you ever used rifaximin without dietary approach?
Well, this is something that was actually, Dr. Pimentel, who really popularized the use of rifaximin for SIBO. He talks about people just eating whatever they want. And honestly, in good conscience, I cannot do that with my patients because people are sick, that they do have food reactions. And so he talked about actually feeding bacteria whilst you're treating them with rifaximin. And this was sort of reiterated to me at the SIBO Symposium that we really see no merit in that. And nobody seems to get any better whether you do that or you don't. In fact, you have more chance of reactivity with using rifaximin and just having them eat whatever. I still think that using the biphasic diet that I've just talked about, have them start with phase 2 and use the rifaximin, you're going to get great results with that.
Are there any herbal alternatives for methanogens over the Alimax and oregano oil? Any experience with pomegranate for such?
Okay, hang on. Emily has just plopped herself down on the floor. I can barely see it now. I'm sorry, what was that?
Are there any herbal alternatives for
methanogens? Oh yeah, good question. Yeah, look, good question. I do see really good results with my berberines as well. It's not just as cut and dry as only Alimax for methanogens. So you can experiment, certainly. And in that example I gave before, where if you just scroll back through your notes, there is one where there was a before and after hydrogen test, and that was just, I believe that was Bactrex, and that beautifully reduced methanogens as well. And we don't really understand why that happens, why in some it'll be effective and others not. We don't understand enough about methanogens yet.
Okay. Does hypothyroidism and vitamin B12 and folate deficiencies affect SIBO recovery?
Yes, because hypothyroidism, if untreated, will affect the motility of the small intestine, and anything that does that will affect stagnation and bacterial growth. But per se, like B12, directly no, neither does folate, other than, I mean, we can go into that rabbit hole of methylation issues, which I will at the SIBO Summit, but you know, but not directly, no, it does not affect it.
Catherine has asked, where can I find a list of herbs contraindicated in SIBO?
There is no such herb, like, other than, I mean, that would just not work, but it's not like it's a contraindication by definition. It's not that you can't use this herb because it worsens SIBO. Although I will say, if you use, for example, if you use certain ingredients in your products that have a prebiotic function, such, for example, this is, well, actually, yes, so slippery elm, for example, has a theoretical contraindication because it is quite mucilaginous, and those mucilaginous herbs can actually be more feeding the bacteria, right? So you can, if you go back to the Foundation's video and just review that, I do talk about that there are certain ingredients that you should avoid when you first start out. Now, bear in mind, when you review that video, that's from 2013, 14? So it's about 2 years old, so updates have happened since then, and that's what these updates are about.
Should visceral manipulation for adhesions be undertaken during antimicrobial treatment or afterwards? Amy has asked.
I don't think it matters. I think whenever you start, this is not a vigorous, you know, it's a very subtle treatment which can be quite profound, and I think if you suspect that, and I'm hoping that Alyssa will talk about that at the summit, is where to find good practitioners, because we are really in need of that, and not just any visceral manipulator is going to be that great. And you have to sort of be a discerning practitioner to really make these alliances, to understand a bit more. So I'm putting it out there that we do need more. We need a database of people that we can refer to, so that we, you know, I'm a firm believer that I'm just part of a healthcare team for a patient, and I assemble my team. I have somebody that does adhesion. I do somebody that works with their nutrition. I even do something called neuroptimal, which helps with resetting their autonomic nervous system. So I don't profess to be an expert in everything, and I think that the more you can delegate to those that really are experts at their craft, the more you will do a service to your patient. So it's just about, you know, understanding who to refer to, maybe talking to these people, that type of thing.
Is it known if the recommended biofilm nutrients are effective in methanogen biofilm also?
Well, we don't know that yet, right? So it's one of those situations where you have to go by clinical presentation and clinical improvement, because there isn't much research done on methanogens and what they respond to.
What kind of minerals would you give?
Well, I often use trace minerals in a liquid form, right? I use a product called Volcamin, which is bioresearch, and you get that from NRG and other distributors. And you know, I have had some reactivity in my very, very sensitive ones, but it's a volcanic ash sort of extract, and I find that it's just very beautifully absorbed by patient and assimilated, I should say. And I find that that's probably one of the most, it's almost like a tonic to them, because people are so depleted and they just don't have the capacity to even sort of initiate certain enzymatic reaction in many cases that are so dependent on some of these trace minerals. So I do find that very helpful.
What are the exercises for motility?
Okay, so this is where you have to go back to either the last year's update or go to sibotest.com what is SIBO / so you have SIBO. This is actually an exercise page for your patients if you have somebody who's chronically constipated. This is actually a great page. Thanks for bringing it up. So have a look around the new website because there's a plethora of information there. But this particular page is called Retraining a Sluggish Colon, and it has exercises and it has tips and recommendations on this one.
Have you any updates on using the healthy fiber, the hydrolyzed guar gum?
Oh, good
supplement?
question. Yes. So, all right. So I talked about this last year. I've used it more, and my word of caution is start it very, very slowly. Sometimes even just wetting your finger and putting it into the fiber and just starting that way. And I don't do it until I'm done with treatment. So again, for those that may have missed this, healthy fiber is hydrolyzed guar gum that has shown to independently reduce methane, and it's very helpful to also sort of feed your microbiome. But I think who's going to talk much more about this is going to be Jason Horlack, who's really an expert in this field. But I have started to use this a little bit based on actually his recommendations, and I've had a lot of reactions in people, so I'm using it very cautiously and slowly, but I've had some people who can tolerate it very well. And it's a relatively inexpensive product, so yeah, you can try it, but very, very slowly would be my recommendation.
And what about the use of monolaurin products?
Have not used it. I know all about it. Monolaurin is touted to be very helpful for candida also. It's an extract of coconut and very antiviral, but I have not used it for SIBO.
If a client has other parasites or bacteria, etc., are you finding the biphasic diet antimicrobials are enough for successful treatment, or are you using a different diet? This one here.
Oh yeah, no, the biphasic diet works really well. Yeah. You do, actually, I will say this, if somebody just comes in with blasto, has no other SIBOs, like if they're negative for SIBO, you can go ahead with a lot of insoluble fiber, right? Because you do want to kind of bulk up your stool, and you do want you do want fiber in there for blasto if they have that. So, but generally speaking, if they have blasto and SIBO, I just do the biphasic diet.
Okay, there's questions, and then we might have to just email you responses.
Yes.
We've got, what prokinetic do you find most effective for constipation dominant?
So an interesting study showed that even using Senna, which I'm not saying that Senna is a prokinetic, but using Senna will reduce methane, and that's because any kind of stagnation increases methane in the gut, right? And not just in the small intestine, but also in the large intestine. And this is something actually I forgot to mention. It's an important point that if you have, or maybe I did mention it, but if you have methane that just stays stable throughout your test, you are probably looking at large intestinal dysbiosis as well. So you can use large intestinal sort of bowel stimulants just to symptomatically improve your patient while you're reducing methane. I found, the Modal Pro effective. I found, I mean, not 100% of the time, but definitely about 40–50% of the time it's helpful. And there's other prokinetics that I mentioned in the last year, but basically your iberogast and your herbs. Look, the fact is that we're quite limited with what we have as prokinetics. There's no doubt about that. There's some talk about melatonin. There's other issues potentially with nerve regeneration with lion's mane and acetyl L-carnitine and those types of things, which are not necessarily prokinetics, but address the underlying factor potentially, but that's early days. We don't have very much, but if you have a very, very constipated patient, don't be hesitant to use some lower bowel stimulants as well.
Is there a process of Saccharomyces boulardii and SIBO for either type?
So, no, I have not found that, other than the fact that it increases secretory IgA and it increases adherence of probiotics to the gut wall. That's definitely very effective, but I am sometimes cautious with using Saccharomyces boulardii in my very sensitive patients because a lot of people are sensitive to fungal elements. And I'll just say that, not to say that everyone reacts to SB, but I've definitely seen that. So there is no, I think, real reason to, other than perhaps using it as a preventative, right? If you're traveling, using an SB formula is helpful, and that we know is to prevent travelers' diarrhea. And people that have, you know, post-infectious SIBO, that might be a good preventative strategy for them down the road. Okay, last one.
Okay, and Ian, I apologise that your initial question didn't come through. So Ian's asked about the elemental diet ingredients.
Okay.
And your thoughts appreciated.
Yes. Okay, so you may not have heard me just talk about the elemental diet, but there is a great handout on Alison's website, siboinfo.com, where she goes, it's right there, it goes through all the ingredients. I'm working on having a formulation being made in Australia. I cannot give you a date when that's ready. I'm very busy this year. It's probably not going to be until 2017 at this rate, but you can look on Alison's site, and she has very clear instructions of where to order some products for your patients. But as far as I know, there isn't an like other than Vivanex, right? Vivanex is the basically conventional meal replacement type elemental diet, which the original research was done on. I do believe you can get that here, or you can have your patients get it, but it's extremely expensive. So have a look at Alison's website and the information that's there.
Okay.
All right, thank you with your wonderful questions, and stuck it out. I hope you enjoyed tonight's presentation, and hope to see you all at the SIBO Summit in October. Have a wonderful rest of the winter here. All right, good night.